topic of today is shockwaves on the one hand and novel EMTT, magnetolith therapy on the other hand. And I will try to share with you my ideas, my experience with these two techniques. And I'm aware that we have a wide variety of disciplines hearing me today. So we have both doctors and non-doctors, we have osteopaths, we have hand therapists, we have massage professionals and so on. So I hope that everybody, regardless of their knowledge on ESWT and EMTT, will get something out of these minutes. So you might be aware of this gentleman. His name is Elon Musk. And you will know that he is born in South Africa, so he has an South African passport, but I discovered that actually he has a second passport, which is issued in Canada. And this gentleman, exactly 9 months ago, was able to send these two gentlemen, Robert Benken and Douglas Hurley, with Expedition 33, with this very capsule to the International Space Station. And furthermore, Elon Musk is able to create shockwaves with every launch of his Falcon rockets. He can create shockwaves in the very area of California, as you see in this Twitter post from the American Geophysical Union. And depending on the angle the Falcon 9 is traveling into the space, more vertical or more horizontal, he can create more circular or more V-shaped shockwave acoustic waves in the aftermath of the launch. But not only Falcon 9 and Falcon Heavy can create these types of shockwaves. I'm a kid of the 70s and raised in the 80s, so I was born with the space shuttle era, and you see here an image of the space shuttle just traveling through the sound of speed with creating shockwaves, as you see in this image. And this is a visualization of two jet fighters going through the shockwave. So this is how physical things create. And there is, and this was the title of a previous talk of mine, an art of applying shockwaves. So it's not enough to buy a machine, and you will get some arguments in the next 45 to 50 minutes on why I'm a true believer that there is more in shockwaves than only adjusting things. And when developing mastery, you will approach stepwise different levels, as a beginner, over an intermediate to a novice, competent, deep, until you become somehow a master. And as you know from ballet dancing, everybody wants to be very successful. However, they until they see what it really takes to get there. And in line, as you know from karate, there are different belt levels based on expertise and based on your practical karate skills. And the same holds true for Korean Taekwondo, with different belt levels. So achieving more mastery in combat fighting. So in the end, education is the key to success in this area. And if it comes to shockwave medicine, and you might go this avenue further, even for EMTT magnetolith, the first step is always education. So shockwave education is usually provided by companies like we do it now with Storz Medical, and by national or international societies. So we have a German shockwave society, we have a worldwide society called ISMST, and we can provide some information by webinars. You can read a number of shockwave medicine books. you should read some scientific publications. You should attend at one time in the future, hopefully, live conferences, or in the end now virtual conferences and courses. And in a second step of Shockwave, in the Shockwave educational circle concept, which I now provide for you for a second time, is on Shockwave's implementation. So start your practice and adjust your ESWT protocols based on studies, based on evidence-based data, based on recommendations you get from others. And then you should evaluate what you do. So note on every given patient what your adjustments were, what your energy levels were, what your number of shots, what your energy level, what your frequency was, and how the outcome is. So you have to have some patient-related outcome measures to measure it, and then to re-evaluate your private Shockwave style, let's say, of how you treat a given indication, say CMC1 osteoarthritis, say Achilles tendinopathy, say frozen shoulder, whatever. And then it comes back again to ESWT education and re-evaluating yourself and getting to a further step of expertise in shockwaves. So there is a concept stated by Malcolm Gladwell in his book Outliers. To become an expert, it takes 10,000 hours. So you might have heard of John Mayer, who is a very fantastic guitar player, and he came out with this PRS, Paul Reed Smith signature guitar, which you see here, just released last year. And I was happy enough to buy the very same signature model of John Mayer. However, buying the very same guitar like John Mayer does not necessarily lead to the same guitar skills when playing this instrument. And this holds true, very similar for buying a Shockwave machine, for buying a Magnetolith machine. So this is a prerequisite, owning this kind of machines. However, then you have to provide and develop your skills in using this. This holds true, as you know, for a scalpel, and I'm a trained surgeon, as you know and heard. This holds true, and I'm not a trained inker, for learning curves when inking. And there is a huge learning curve in terms of shockwave medicine, and the same holds true for magnetotransduction therapy. And we just, I gave a presentation on this issue on the last ISMST conference in Beijing, China, when we were able to, for the last time, to meet in real life on an international shockwave stage. The ISMST, the International Society for Medical Shockwave Therapy, has come up with indications, and these indications are differentiated in indications for beginners, for advanced, and for expert shockwave users. So a beginner level and approved standard indications, these are all noted on the ismst.com webpage, and you can have a thorough look on, and should have a thorough look on this. Usually chronic tendinopathies, as you see, bone pathologies like delayed bone healing, non-union stress fractures, and some skin pathologies like delayed and non-healing wounds, skin ulcers, and non-circumferential burn wounds. On an advanced level, we have different types of tendinopathies, say rotator cuff tendinopathy without a calcification, the medial epicondylopathy, so the golfer elbow, while the lateral tennis elbow is a beginner indication, peroneal tendinopathies, bone marrow edema, Schlatter disease of the adolescents, or cellulite, for example, if it comes to aesthetic treatments. And this differentiation is based on the number of available evidence-based data and the estimation of the ISMST board members and their experience, that you should not start, if you are a very novice shockwave user, with, for example, a shin splint or cellulite or a golfer elbow as your very first patient, because your success rate will not be that very high. And there are some expert indications just to make the scope, like osteoarthritis, Dupuytren disease, Dutcher-Wern disease, trigger finger, spasticity, and others, say that, again, a novice shockwave user should not start with that very expert indications. A shockwave is a rapid, or is characterized by a rapid and very steep incline. And the combination or the differentiation of focused and radial shock waves, both are acoustic waves in the end. They travel until different depths, and they might pose different biological effects, which is very important to acknowledge. So a focused shock wave is in the end a true shock wave, physically wise speaking, where the generator can be differentiated based on the manufacturer. So Storz is providing an electromagnetic generator. Different competitors are providing electrohydraulic or piezoelectric generators. And these are all focused shock waves. However, energy flux densities, study results, and so on are not necessarily comparable, because even though these are all focused shock waves, the generator is different, therefore your energy flux density are different. And on the other hand, there is radial pressure wave, or radial format called shockwave therapy, and the ISMST has renamed the radial shockwave therapy and radial pressure wave therapy for a number of reasons, including physically wise. And this is in the end an ballistic treatment where a acoustic wave, say a pressure wave, is transferred to a given body, as you see, and the connector to the skin is the applicator. And I will talk shortly on different applicators, because in technological wise, the material might be different, the diameter might be different, and therefore even with the same pressure and even with the same frequency, you will obtain different biological effects in terms of travel distance of your pressure waves, in terms of pain during treatment, location-wise, and so on. So there is a big chance to adjust your radial pressure waves with different applicators. And like in a sound studio, as you see, you have a number of different adjustments possible. I told Bob Remignton already that I restarted my golf expertise, and you as a golfer have to adjust to different locations and different weather conditions, as you see. And this is Hanover, Germany, and we just had pretty much of snow, as you see here. This is just 3 weeks ago, where my golf club was fully covered with snow, and this is, you know, Canadian-like area and atmosphere. So if you are in golf, you can fine-tune your golfing with different tailored irons. The same holds true for different putter. And the same holds true for different applicators when using your radial pressure wave therapy. So it's not only the diameter which differs, but also the material with your different applicators. And Storz is providing, in contrast to competitors, even some fascia applicators and some different materials within your applicator. So they vary in terms of diameter, in terms of material, and in terms of indications. And for example, if you have same diameter, say 15 millimeters, there are softer or very soft applicators where you feel a very gentle pressure wave, for example, the F15 going over the steel, going over the ceramic, leading to gold, for example. And there is a novel applicator called the Atlas, which is a silicon tip, somehow the same like in focus shockwave, where you have your standoff silicon tip, and this silicon as a standoff in your radial pressure wave will allow to lower the pain during your treatment. So now can come true, that you can treat children with the Osgood-Schlatter disease, you can treat some epicondylitis, which is very painful, especially if you are directly hitting the bony prominence or different areas in the face, for example. So the Atlas is a very soft and the softest applicator which is available in the moment, followed by, for example, the F15 plastic tip and the C15 ceramic tip. And these are some images 2 years ago already, I saw, with some more pilot applicators, as you see. And these are only 2 patients with epicondylitis I treated on that very July 3rd with the Atlas applicator on the left-hand side, so no pain during treatment. The same 1 bar, 8 hertz, 3000 shots with the C15 was pain 1 out of 10. And with a pilot Deactor Ceramax applicator, the 2 patients had significantly more pain with the same 1 bar, 8 hertz, 3000 shots. Just to give you an idea of how huge the variety in terms of your different applicators is. And the difference between these 2 is only the deactor. So the holding of the applicator is different from this to this, just to give you an idea. So in the future, there will be hopefully some more applicators like the Atlas. There might be a tendon flat tip, and there might be even an aesthetic round tip, where you have some more beneficial effects in terms of coupling. And like these are my hand surgical instruments in my hand surgical OR. I have different applicators for different indications. So say for hand surgery, I'm using quite a lot of the Atlas, of the Deep Impact 15, the C15 end, which is not available for you. It's only a pilot one, the Deactor ceramic. For myofascial applications, I have different applicators, say the D35 in gold and in steel, or the ceramic one again. And my aesthetic setup, for example, is using the MP1, which is a very nice handsome machine, 8 kilos only, portable, and you can mount your different applicators even on your different probes, and you can immediately change your probe by clicking on, and this is only a 1 second maneuver to change the different probes with the MP1. So this was everything on the radial, and now we dive deep in focused. The history of focused shockwave started with electrohydraulic devices in the early 1980s, followed by piezoelectric in the 1985 and electromagnetic 1986. And the current Storz electromagnetic cylinder coil was established actually in 1989, just to give you an idea. And this is how a rendering of a focused shockwave is happening over a tissue depth of 8 centimeters. So you see that the shape of the shockwave is changed by penetration depth, as you see in this visual rendering of a focused electromagnetic shockwave. And there are huge physical differences in between radial pressure waves and focused shockwaves. This is the reason why, for example, the ISMST differentiates by definition very sharp in between both. So in terms of pressure, for example, you have a 100-fold difference. So in the end, roughly speaking, the energy levels you can achieve and provide pain-free or with less pain with a focused device are not comparable to a radial one. So you cannot provide the very same with a radial device than with a focused device, just to make it clear physical-wise. So why consider focused shockwaves? So bones are healing much faster with focused shockwaves. And this is a Jones fracture, which is a metatarsal 5 fracture in sportsmen. And these are gentlemen from Japan, from Funabashi Orthopedic Hospital. And they showed a very nice, yet unpublished study in Japanese J-League professional soccer players were suffering a metatarsal 5 fracture. And the standard treatment is antegrade screw fixation. And it took them 10 weeks for bony healing by CT scans and some 12 weeks to go back on court. So return to play, metatarsal 5 fracture, antegrade screw fixation, 11.7 weeks in Japanese professional soccer players. They took another 5 of these players with the very same operation. So antegrade metatarsal screw fixation, and applied focused shockwave on day 1, 3, and 5 after the surgery. And look what happened. The players were healed at 7.8 weeks, faster by CT scan, and they were back on court at 8 weeks, not at 12 weeks. So a 26-day benefit in return to playtime by the combination of standard operation and focused shockwave, day 1, 3, 5 afterwards. Unpublished yet. Skin heals faster. We have compelling evidence, for example, in this very randomized controlled trial, that skin harvesting sites heal 3 days faster by a single application of focused shockwave. And the same holds true for second-degree superficial burn wounds, which has been published by my friend Bernd Hartmann in the Annals of Surgery. And this is just as an example, because I'm aware that some hand therapists are among the audience, a lawyer, female lawyer, who visited me in the first COVID wave with the superficial degree, 2A degree burn wound, and I treated her. And as you see, ending of March and beginning of April, we could improve epithelial healing by the application of focused shockwave in these female. In trigger fingers, you might sometimes see the local swelling, and I'm applying now high resolution ultrasound, and you see here high resolution ultrasound of the superficial and the profundus flexor tendons. And I'm now able to measure, for example, elasticity in these two flexor tendons by a sophisticated ultrasound, let's say, modules like shear wave elastography. And we measure now how shock waves, radial and focused, and EMTT is influencing elasticity of a given tendon. And my trigger finger therapy in the early beginning, 15 years ago, when I was still in a university hospital, was surgery. Then I started some 12, 13 years ago with some injection therapy prior to surgery. And then some 10 years ago, I started with applying shockwaves, both radial and focused, in trigger finger. And we have now a number of publications, as you see here, some 4 or 5 publications, showing that both radial and focus are able to improve trigger finger complaints quite significantly just before surgery. And there's another compelling idea of using shockwaves. You might have heard of hyaluronic acid, which is used for osteoarthritis or for tendon repair, for example. And the hyaluronic acid is binding on the effector cell on a receptor called CD44. And interestingly, and just published by my colleague Maria Volpiani from Rome in Italy, they could show that both pro-inflammatory cytokines were reduced and anti-inflammatory cytokines like interleukin-1 were improved by focused shockwave, as you see with a focused electromagnetic device, medium energetic. But of note, the CD44 receptor could be significantly improved by shockwave therapy. So if you do focused shockwave, you can pre-treat your tissue, and the tissue then provides much more of CD44 receptors. So your hyaluronic acid after your shockwave will have much more efficacy. Just published. So preconditioning of your tissue, focus shockwave, CD44 hyaluronic acid injection, receptor induction, and then more receptors and more efficacy. So in shockwaves, and if you go to Medline and PubMed.gov, you see we see some 200, 250 publications every year with ESWT. And the majority of publications is done on focus shockwaves. However, as you see in the yellow curve, radial pressure waves are coming up. However, just on a scientific comparison, we have much less information scientifically on radial pressure waves, in contrast to the vast majority of papers dealing with focus devices. This is a very, very important issue to consider in the moment. So moving forward to EMTT, it's the abbreviation for extracorporeal electromagnetic transduction therapy. EMTT is a novel technology. It is using and applying high frequency or oscillating magnetic impulses. And you might remember this gentleman from the very beginning of my talk. And if you have a Tesla, I don't have one, you can supercharge your Tesla on this supercharging filling station. And as I'm an avid Apple user, this is one of the products which never came out, notably. This is a supercharging station just provided, I think, with the iPhone 10, but never came into life by Apple. However, Storz developed a supercharging module for your very iPhone. So this is what I'm using on my desk. And in the end, the EMTT, extracorporeal electromagnetic transduction therapy machine with the Magnetolith, is somehow a supercharging machine. And you might have heard of Pantone. These are the two colors of this here, the illuminating yellow and the ultimate gray, which just have been proposed as the colors of this very year. And Magnetolith is supercharging, in the end, your tissue, like the supercharger your Tesla does. It will activate your healing processes, which are inherent in your cells, in your tissue, to a much higher degree. And if it comes to oscillating magnetic fields, James Maxwell formulated a complex formula, in the end showing that electric fields create magnetic fields and vice versa, and that frequency matters in this regard. So the basic principle of a EMTT machine is a very high voltage power supply and the capacitor and the switch. And then you have an applicator coil. And this is a single EMTT impulse derived by a magnetolith. And if you look this very closely, you see here on the x-axis the time, it's microseconds. And you see a high oscillation, which becomes smaller and smaller over time. And we have now here 100 microseconds, which is very, very fast. And you see on the y-axis the magnetic field strength in millitesla. Based on a number of studies, it is clear that to elicit a biological response by a magnetic field, it needs a threshold of at least 10 millitesla. So your impulse has to be strong, at least 10 millitesla or more, to create a biological response. If you are less than 10 millitesla, nothing will happen in your cell. So 10 millitesla or more is eliciting a biological response. And if you then count how many impulses or how many biological responses are created by a single EMTT impulse, you can count. I counted it. These are 10 impulses larger than 10 milliteslas within 70 microseconds. So 10 oscillations in 70 microseconds. Bear this in your mind. The Magnetolith is providing up to 10 hertz, so 10 impulses, depending on your energy levels, but 10 impulses per second at best, which means one impulse is 10 oscillations, biological active. So if you have 10 hertz, you have 100 impulses, biological active in 1 second. 100. If you compare a shockwave to the oscillation rate, you see substantial differences. And in terms of the mechanism most likely underlying the biological effects of EMTT, we should have an idea on ion channels. And there are ion channels in the cell membrane modulated by ligands, modulated by voltage only, modulated by mechanically, or they are always open, like the always open timer in a Mini, by the way. If it comes to ligand-gated ion channels, you have ion channels for potassium, for sodium, for calcium. And I myself actually did my doctorate thesis in antiarrhythmic drugs on a different, very high-speed potassium channel called IQUR. And we have some more than 8 different potassium channels alone in the heart, just to give you an idea of how complex things are. So on every or different electrolytes, we have different ion channels, put it simply. And my friend Ludger Gedesmeyer showed beautifully 10 days ago in his talk for Storz how we believe the working mechanism of EMTT might well be. So every cell has a constant membrane potential of minus 10 millivolt. And these fast oscillating magnetic fields interact with these local electromagnetic fields, and they change ion channels. Therefore, effects on an intracellular level on different locations can be estimated, like cytoskeleton remodeling, the changing of the ion channels, the changing of the permeability of a cell membrane, migrating membrane proteins, and so on. And 2 major effects are, on the one hand, electroporation, whereby substances from outside of the cell get easier access within the cell by the voltage effect of the electric fields. This is an effect called electroporation, which might be very interesting if it comes to drug delivery, even for vaccination. Even in this COVID area, it might well be that by electroporation, one might facilitate and enhance the activity of a drug delivery for a vaccine, for example, your mRNA into the cell by electroporation. And the second effect we are aware of with the EMTT is a piezoelectric effect, for example, in bones. So piezoelectric and electroporation appear to be 2 major mechanisms involved in the EMTT mechanisms. So I'm aware that on the market, there are a number of pulse electromagnetic field therapy machines like BTL, like Zimmer, like others, called PEMF, and the EMTT, which I present to you. And if you compare the oscillation rate of the EMTT in green and the PEMF machine like BTL, Zimmer, or whatever in blue, you see that we have some as I mentioned, high oscillating biological active oscillations with the EMTT, so one oscillation in 7 microseconds, while it takes some 280 microseconds for just one single oscillation with a PEMF device. So comparing EMTT and PEMF only by the oscillation rate, EMTT is 40 times faster. 40 times, 40. And this is what you see here. It's oscillating quite rapidly, while PEMF on the right-hand side is really slowly progressing. So EMTT impulse oscillation is 40 times faster than PEMF. So these are physically wise not comparable machines, completely different. On the other hand, we met last summer in between first and second wave of Corona in Hanover for the first EMTT Worldwide Expert meeting. And we came out with the definition of effective transduction power measured in kilotesla per second, which is the mean or another feature distinguishing PEMF from EMTT. And the assumption is the faster the magnetic field rotates, the higher and more pronounced biological activity is. And this is called effective transduction power, or like similar horsepower in a car, for example. And by definition, PEMF devices have lower than 60 kilotesla per second, and EMTT devices higher than 60 kilotesla, which you can see here. The Magnetolith on the left-hand side, 65 kilotesla, and the TerraCell machine, for example, with 105 kilotesla. And competitors like PEMF machines, the BTL or the Zimmer, with less than 60 kilotesla, and they measured especially in the coil, while the EMTT devices were measured even distant to the coil, 4 or 5 centimeters. And as of now, we have no comparable data, but it appears if, for example, you measure EMTT directly on the coil, your effective transduction power is even higher. On the other hand, if you measure BTL or Zimmer 4 or 5 centimeters away from the coil, the effective transduction power will even be less pronounced. So the difference in between both will be much more substantial. So physically wise, this is what you should take with you when characterizing the EMTT. The effective transduction power is higher than 65 kilotesla per second, and you see 10 biological active oscillations within 70 microseconds with one impulse. So very, very fast oscillation. So the idea now is to combine maybe shockwaves and EMTT, because both are healing accelerators. And the idea behind is best healing faster. And this is of utmost importance, for example, in sports medicine. And I'm treating or helping a number of patients, high-level athletes in soccer, in skiing, in track and field, whatever. And the sooner they get better, the better it is. And in sports medicine, it always is a measure of combination of different tools. So not the one or the other, but combination. As I showed you before, operation plus, for example, shockwave therapy in the case of metatarsal 5 fractures. And the very first patient I ever, or professional patient I ever treated with a EMTT device at that point of time, a TheraCell machine, was this defender from a German professional soccer club on November 29th in 2016. So some 5 years ago, I started combining therapies in his painful patellar tendon using focus shockwave, injection therapy with hyaluronic acid, and EMTT treatment at that very point of time. And speaking on EMTT, I cannot speak without mentioning my friend Ludger Gerdesmeyer. And he is a driver of EMTT, and next week on, I think on Tuesday, he will speak again on biological and the clinical applications of EMTT on the Storz webinar. So you should tune in. If it comes to, for example, swimming athletes, just as a case report, this is a phalangeal fracture, as you can see here in 3D digital volume tomography in my practice. And this fracture leads to training time loss. So this swimming athlete who's competing on the very edge of the national level had an interest of faster healing. So I combined focused shockwave for bone healing, high energetic, plus EMTT treatment. And this is after just 2 treatments. And this is before, and this is just 4 weeks after, as you see, not a complete, but a profound consolidation of the fracture. So we can obviously even shorten the time period of bony healing. Some data on the EMTT. We with the help of Tim Klüter, Ludger Gettesmeyer, and others, we had a very nice study on 86 patients with rotator cuff tendinopathy, and they either received high energetic focused shockwave, as you see, 3 sessions, or the combination of focused shockwave and EMTT with a Theracell machine. This was a randomized controlled trial, and you see here the improvement in pain levels at 6 weeks, 12 weeks, and 24 weeks for the shockwave group alone, high energetic focused. So at half year, we saw a 42% improvement in pain, and the combination of ESWT and EMTT at the very same time point could improve by 88%. So more than double the efficacy in terms of pain reduction at half a year time in combination with rotator cuff therapy. And the same holds true for the constant Murray score as a patient-related outcome measure. And this is how in the very COVID times now you can do treatments with your garments, your mask, and so on in my practice, for example. One study on the Achilles or the painful Achilles tendon. And Ludger did a very nice study with Amol Saxena and Brian Fulham from the US, published in the Foot and Ankle Surgery Journal. And they included mid-portion Achilles tendinopathy patients. And they did either standard treatment or the combination with EMTT, and could show a significant improvement in pain reduction and in the Rolls and Morsley scale when applying additional EMTT in combination to standard treatment. And for example, this is an 80-year-old golfer who had suffered an Achilles tendon rupture in my and came to my practice for a conservative approach, and I'm applying shockwaves and EMTT to facilitate faster Achilles tendon healing in this given patient. So some data on bones. This is a 33-year-old patient with a symphysitis, which you can see an MRI with a T2 bone edema in his left and right symphysis. And this is how treatment with a EMTT in symphysitis looks like. So you can leave the trouser on and go deep with your penetration of the EMTT, which penetrates up to 18-20 centimeters. And there is a nice pilot study in osteoitis pubis published again from the group around Ludger Gettesmeyer, and they could show that a significant improvement of pain was achieved after 4 treatments with the EMTT alone in symphysitis. And in some cases, they even did before and after MRIs. You see the bone edema in this given patient more on the lateral left side, and the resolution of the bone edema in T2 to T2 weighing MRI in this very patient. This is a patient of mine with a scaphoid non-union. He had several operations and so on. And in the first Corona lockdown in March 2020, he came to my practice with a non-union after operation, or the second revision surgery. So I applied focus shockwave and EMTT 3 sessions on this very patient. This is how it looked, how I applied it. So 4,000 shots per session, high energetic, plus 6,000 shots with a Magnetolith. And then I did 3D volume tomography with artifact resolution. And we could show even 5 weeks after 3 treatments a substantial healing of his scaphoid non-union, which did not heal 10 years beforehand. And this has just been published end of the year in medicine. So you can look, it's open access. Next case, another hand case, metacarpal 5 non-union in a farmer. Mainly the same approach. First of all, failed surgery, revision surgery, failed again with a bone graft. So again, 3 sessions focus shockwave and magnetolith, as you see, and this is 8 weeks after the grafting, where you can still see the non-union of the graft. So focus shockwave, radial, EMTT treatment, and this is before March 20. This is April 30, so some 6 weeks in between. And you see, let's say, an immediate improvement in the bony consolidation of this non-union in this farmer. And this has just been published in German hand surgical journal, Harniplan. So CMC1 osteoarthritis, as I'm aware, some hand therapists are around the audience. You are aware of the Eaton-Littler classification, and with these machines, which I'm using now in my practice, you can really nicely show on left and right side how the CMC1 joint is looking like Eaton-Littler osteoarthritis grade 1, grade 2 with some subchondral sclerosis, narrowing of the joint space, loose bodies larger than 2 millimeters, and so on. So my usual approach is starting with orthesis, then shockwave, then injections, then surgery. That was my usual approach, and there is a very nice study on shockwaves alone in contrast to hyaluronic acid, published in Italy, and with patients who had already 8 years of pain, and you see a substantial improvement in both groups. So focused shockwaves and hyaluronic acid injections were very successful over the first 3 months. However, at 6 months follow-up, the shockwave group was still getting better, while the hyaluronic acid group is getting worse. So in this study, where they did either shockwaves or focused shockwave or intra-articular hyaluronic acid, the 3-month results were quite similar, and the 6-month results are more in favor of ESWT. And I'm now applying, and we don't have data yet, the combination of ESWT and EMTT on the CMC1 joint osteoarthritis, and especially in bilateral cases, it's very nice if you have this position to treat both joints simultaneously, and the same holds true for Heber-D and Bouchard osteoarthritis, which are very, very rewarding indications in this regard. So as of now, I'm overlooking myself 1,082 magnetolith treatments. 70% of my patients are males, main age 53, as you see, and I usually apply 3 sessions per patient, because in only 4% of my cases, I'm doing EMTT only. The majority of my patients are treated in the combination, so 69% are treated with EMTT and ESWT simultaneously, and another third of my patients are treated for various indications with EMTT, ESWT, and injection therapy. So I'm mainly a combinatory, or I'm using a combinatory approach. I'm using it for a number of tendons of the upper and lower extremity, as you can estimate. I'm using it for a number of bone problems like bone edemas, non-union, stress fractures on the upper extremity, on the trunk, as I mentioned, symphysitis, pedicle problems on the lumbar spine, for example. I'm using it for stress fractures, osteoarthritis of the lower extremity. And I started to use it for improved ligament healing on the thumb, for the ulnar collateral ligament, in ankle sprains, or on the medial side of the ankle as well. Usually, and this is as of now, however, I'm adjusting it, I used to use the EMTT in tendons with some 3,000 shots, because I'm doing it mainly in combination with focused shockwave. Bone edemas a bit more, 4,000 shots, and non-union 6,000 shots per session, usually 3 sessions. And I'm approved to show you a intermediate analysis of 1,088 treatments in the Storz EMTT register. This is the age distribution with these among these register data, and the majority of patients were treated on energy level 8 out of 8 in this register. However, some 8-9% with 7 or level 6 energy levels. So the majority is on energy level 8. In terms of frequency, the majority is doing 8 Hertz. However, there are some people and patients and indications where we might have maybe even better results with lower frequencies like 4, 5, or 6 Hertz. And the mean number of pulses in this registry in the moment is roughly 4,000 shots per session, just to give you an estimate of what we oversee in the very moment. So some recipes from my point of view: in shoulders, combination focus shockwave, 2,000 shots as you see, radial pressure waves, and EMTT. Same holds true, very similar, for Achilles tendinopathy, where I combine focus shockwave, radial pressure waves, and EMTT. For symphysitis and bone edema, I usually do 4,000 shots in a single session of focus shockwave. I might apply radial, however, on bones itself, it is not so efficient. And the EMTT with a higher number of impulses, as you see. And in osteoarthritis, I combine again focus shock waves, radial shock waves on the trigger points, and EMTT with 4,000 shots. And in non-unions, I usually do not do radial, but focused, high energetic, and EMTT. So some more ideas to coming to the end. For example, in greater trochanteric pain syndrome, you can use a novel device developed by my friend Stefan Swart, the trigger point finger finder, combining high energetic focus shock wave, radial pressure waves, the vibration tool with the reactor HF with different frequencies, which is the topic of today, and the Magnetolith in the end. Or here, trigger points around the shoulder, identification, marking them on and combining focus and radial and the EMTT. In Schlatter, it is a very nice machine to apply. You can do ultrasound as you see in Schlatter disease, and you should do it. In shin splints, you might see, to rule out some bone edema, these observations in shin splints like periostitis, and I apply it usually in this manner when using shin splints. Stress fractures are very rewarding, combining focus shock waves and the EMTT machine. Bone edemas, as I mentioned, this is a professional soccer player. After a ligament injury, he has some bone edema in his talus, so you can get rid of it. My oldest patient to date is 91 years with a spinal stenosis, as you see, and my youngest patient to date is a 9-year-old with some patella tendon pain, receiving some EMTT. So some experimental data on the end. Meniscal tears, as you have heard of, are now playing around with very high resolution ultrasound, and this is a probe with 33 Hertz, and this is an inner meniscus or medial meniscus tear where you can really see the tear for the very first time very clear. And there is a recent animal studies suggesting that focus shock wave might help healing in at least animals in meniscal tears, although it is avascular. And I started to use it in some patients where no locking is available in lateral or medial meniscal tears. And that's how I do it. I do focus shockwave, high energetic, as you can see here, and apply in combination the Magnetolith with some encouraging results. Last case on Dippertrons, because Bob said I should touch in hand as well. I did some nearly a decade, the Xiapex collagenase injections, which you might aware and heard of. indigenous disease instead of operation. So you inject your collagenase in the cord. This was my first patient, actually the first patient in Europe in June 2011. Injection under local anesthesia in the, for example, in the ulnaris region, doing cord breaking on the second day, and a very pleasant result after 10 days. And later, this is a bilateral case before and 3.5 years after, with very nice clinical results. The biggest study published in the New England Journal of Medicine with some 300 patients did either saline injection or Xiapex injection with a favorable outcome in the collagenase injection therapy. However, the numbers of adverse effects, if you look in the original papers, was quite substantial. So peripheral edema, contusion, hemorrhage, pain, tenderness, ecchymosis, quite significant in the collagenase. So a case of mine, 60-degree MP joint contracture, injection of the Xiapex with combination of low-level laser, radial shockwave, focus shockwave, and EMTT. However, this massive reaction, as you see, massive swelling on the day one. Or another patient, 90-degree PAP joint contracture, and this is before and after cord breaking. You see the ecchymosis. So when using collagenase, even you combine it with your adjacent machines, you might enter these adverse effects. So I put in the Magnetolith in this setting to facilitate healing quite substantially. And this is one of the last patients I did in the summer, a female patient with chronic lymphatic leukemia, having a very unpleasant protein kinase therapy medication. And this is beforehand, shock waves, EMTT before cord breaking, injection, then cord breaking. And you see, this is immediately after, before cord breaking, on the day after the injection. As you see, substantial ecchymosis, applying laser, applying the Atlas or radial pleasure waves with the Atlas. You see here, applying DI15, focus shockwave, high energetic, and you see this is only 4 days in between. So you can really facilitate healing quite substantially. And I add, as you know, as hand therapist, using flossing and kinesiotaping and so on. So every trick, what I have, and EMTT is putting in this regard, in this regimen, quite nicely. So coming to the end, this is German Josef Beuys, who will turn 100 in this very year, 90. So he was born 1921. And shockwaves and EMTT, in my way, are superior healing accelerators. And one of his famous images of Josef Beuys is healing helper. This is Gesundheitshelfer in German. So thank you very much for your attention.